Good afternoon and welcome to our webinar, Striking a Balance, Preventing Falls in Older Adults with Diabetes. My name is Betsy Rodriguez and I will be your moderator today. I am a Latina woman wearing a brown cap, black and white glasses, and a terracotta top with a blurry background. Thank you so much for joining today. Before we begin, I would like to go over some information about the webinar. At this time, we are required to share our disclosures. Planner has reviewed content to ensure there is no conflict of interest or bias. The finding and conclusion of this presentation and those of the author and do not necessarily represent the views of CDC. Photos used in these presentations are from CDC products or licensed through Canva and Getty Images. During the webinar, if you have questions for our speakers, please type them in the Q&A box that is below. You see the arrow showing over there. If you want to direct your questions to a particular speaker, please feel free to note that in your question. We will do our best to answer all questions during the Q&A portion of this webinar. If you have questions about where to access this webinar, once it's over, or other technical questions, please use the chat box. We also encourage you to use the chat box throughout the webinar to share your thoughts or on the content that you will hear. Here are the objectives for today's webinar. We're going to be working around to identify diabetes-related risk factors that contribute to an increased risk of falls among older adults. We're going to be doing summaries of the importance of foot and lower limb health as key part of managing diabetes and reducing complications. And finally, we're going to explore the evidence-based resources and tools to promote lower limb health and reduce the risk of falls in older adults with diabetes in clinical and in community-based settings. But before I introduce our presenter for today, I want to frame today's section in the American Diabetes Association ADA Standard of Care 2025. In particular, I would like to highlight Standard 12, which includes foot care and the importance of helping people with diabetes be aware of and prevent complications related to the health of their feet, and Standard number 13, which covers care for adults, including screening for fall risk. We will share links to these specific standards in the chat. And now, I am very excited to introduce today's speaker, Dr. Gary Rothenberg. Dr. Rothenberg is a clinical associate professor of internal medicine and podiatry at the University of Michigan Medical School. Dr. Rothenberg is a practicing podiatrist with 25 years of experience, focusing his practice on preventing complications among people living with diabetes. He has a particular interest in fall prevention, also serving as the director for the University of Michigan Medical School research-based fellowship in limb preservation. So thank you for joining us, Dr. Rothenberg.
Thank you, Betsy. It's really a pleasure to be here with you all this afternoon. I want to thank you all for the invitation. And as Betsy mentioned, my name is Gary Rothenberg. I am zooming in from Ann Arbor, Michigan, where we're having a beautiful spring day. In my home office, I'm wearing my blue shirt and my yellow and blue tie that my daughter picked out. Betsy mentioned I have 25 years of experience, hence my gray hair that is on my head. So I'm really excited to be with you all today and talk about this topic and specifically focus on what role podiatrists can play in falls prevention. So we'll start off the session today really talking and giving some overview statistics regarding fall risk in older adults. And then we'll move on and kind of work the funnel, if you will, specifically talking about falls risk among people living with diabetes and the risk factors that may be unique to that patient population, which I know many of you work with on a daily basis. So just to level set, we have some statistics here in front of you. You may be familiar with these, but I'll remind you that each year, 1 in 3 adults over the age of 65 will experience a fall. And the problem, of course, is that once you've had a fall, you may develop a fear of falling, or you may also experience multiple falls. And the statistics will say that 50% of people who experience a fall will experience a subsequent or multiple falls within that same year. We also know that about 3 million fall injuries send older adults to the emergency department every year. And it doesn't always end there because they may be seen in the emergency department, but of those 3 million, about 100,000 will result in hospitalization. So you all know the story. It may be a patient that you work with, an older adult. It might be a loved one that you know their story very well. They have a fall, they break a hip, they end up in the emergency department. A surgery may be required for hip repair. Then they end up in a skilled nursing facility and the subsequent quality of life impairment. So the CDC estimates that among these 3 million fall injuries per year, there's about $50 billion. That's billion with a B, $50 billion annually spent in direct costs for falls. So, of course, from our perspective in managing patients, there's the quality of life impairment, but to the system, there's a very, very big financial component to this as well. So if we think about what are the risk factors for falls in older adults, we come up with many, and I will consistently refer to evidence-based medicine. But what you see in front of you is actually a list for risk factors among older adults. And again, I don't think that some of them will surprise you to be on this list, but what's important to realize is this list is actually in kind of an order of the strongest predictors of falls at the top, and then the least common, but still making the list towards the bottom. So again, previous history of fall is the strongest predictor of a subsequent fall. Balance impairment, visual impairment, multiple medications, these things probably don't surprise this audience. But other things like incontinence, arthritis, and we're going to talk about some of those within my role as a podiatrist and helping to support foot health in how that link is associated with falls prevention. So here are some other statistics which I think are really important. And we also can think about the cumulative effect of those risk factors, which were just seen on that previous slide. If you are an older adult and you have none of those risk factors, the risk of falling is 8%. When you combine risk factors, there is this cumulative effect. So with 4 risk factors, and it's not so hard in our older adults, especially those with diabetes, to kind of accumulate those on a problem list, the risk of falling grows to about 78%. But what another important statistic that I wanted to bring to your attention is one of the strongest predictors of falls is immediately occurring post-hospitalization. So the risk of falling quadruples for a patient within 2 weeks of discharge from the hospital. And again, this clinical scenario might not seem uncommon or unusual to you all. A patient is hospitalized, they end up deconditioning as older adults. Maybe there are some medication adjustments. The patient goes home and they're expected to return to their usual activities of daily living when they're adjusting to new medications coming out of a situation where they're very deconditioned. So it makes clinical sense, I think, to many of us, but just for awareness, we need to realize that that immediate post-hospitalization period is critical in evaluating for fall risk and fall prevention. So with some of these statistics in mind, I now want to focus a little bit more on diabetes. And we all have this common denominator of helping to for people living with diabetes to continue to have productive, healthy lives. And so, what I want to explore over the next few slides is that relationship between diabetes and falls. We know that just having a diagnosis of diabetes will significantly increase the risk of falls. And the literature would say that somewhere between 25% and upwards of close to 40% of older adults with diabetes will experience a fall annually. And again, there is morbidity and mortality associated with those falls of injuries, loss of independence, and reduced quality of life. So, our goal today is to really understand this issue and hopefully come up with some interventions and some recommendations on how we can educate our patients to avoid these complications. So, if we think specifically about patients with diabetes, the risk factors that are very unique among them really fall into these main categories: diabetic peripheral neuropathy, hypoglycemia, and then history of foot ulcers and footwear. So, I commonly ask my patients about symptoms of diabetic neuropathy. I bet you all do too. And we're very focused on the sensory component of nerves. So, are they experiencing burning, tingling, pins and needles, or numbness? And this, of course, is very common among our patient population living with diabetes. But what I have to consistently remind my colleagues and remind my patients is that nerves have two functions. They are both sensory and motor. So, while yes, we understand that numbness can, of course, be a risk factor for falls with diabetic neuropathy, we also have to appreciate the motor component and that disconnect, if you will, between the nerves in the feet and the ability for the muscles and the brain to conduct that movement that we expect in normal ambulation. In terms of hypoglycemia, this audience knows very well the symptoms of hypoglycemia may include confusion, blurred vision, and balance issues. Obviously, of course, predisposing these patients to falls. And then when we talk about foot ulcers and footwear, and we're going to talk a bit later about ideal footwear, but oftentimes in patients who are managing and trying to heal diabetic foot ulcers, the podiatrist, me, I feel like an accomplice in this falls risk really aspect of care. Because as you all know, we put patients in offloading boots, special surgical shoes, we put them in casts. And unfortunately, as they're trying to heal a foot ulcer, we actually potentially increase their risk of falls by giving them an uneven boot to walk with, which they're not level with the other shoe. So we really have to pay careful attention in this patient population who are experiencing chronic foot wounds as to what they are wearing and how can we, again, mitigate the risks of falls as we're trying to battle one complication, not cause another problem. If we also think about the unique risk factors among people living with diabetes, we have to think about medications. Many of these, as I always say, nobody comes into my clinic with diabetes alone. Everyone has hypertension or coronary disease. And certainly blood pressure medications to manage their hypertension can have a significant effect. You all know about orthostatic hypotension and these interactions between these medications. But simply being on certain medicines like gabapentin, so very commonly prescribed among patients living with diabetes for their neuropathy symptoms, but we know that there's a sedative effect. We know many patients who take gabapentin in the evening may wake up very groggy. So, how do we, again, understand the role that certain medications, those that we're also prescribing for mental health issues, depression and anxiety, also have a sedative effect? So, certainly understanding the role of medications and polypharmacy that plays in risk for falls is really, really important. We talk about visual impairment. Again, so common among people living with diabetes to have retinopathy. and visual impairment. So making sure that these patients are receiving their annual visual exams, annual eye exams, making sure that their glasses are appropriate, that they're wearing their glasses to help, again, avoid falls. And then we also know that as we age and living with diabetes, there may be some muscle atrophy. Specifically in the lower extremity, what we see is a tightening of a lot of the musculature, specifically the Achilles tendon. And that is very common in people with diabetes. So we have decreased muscle strength and impaired proprioception, or the ability to understand where your foot is in space. So again, it's this combination of nerve issues, musculoskeletal issues, pharmacy, visual impairment that are really the unique contributing factors among people living with diabetes. So I do like to really keep my talks evidence-based if I can. And I really love a systematic review, because essentially what somebody does is they review all the literature regarding a specific topic, and then they summarize it for us. So I found this systematic review, which the title tells us what it's looking at, and I found it particularly useful and hopefully pertinent to this talk today. So this is a systematic review on the impact of neuropathy, specifically among people living with diabetes, on activities of daily living, postural balance, and risk of falls. This is a systematic review of 34 papers, and with a significant conclusion, as you might expect, because I'm sharing it with you today, that neuropathy has a known evidence-based negative effect on postural balance, gait function, how we walk, and that combined increases the risk of falls among people with diabetes. So the literature supports this. Now I want to spend just a few minutes. Again, I'm very proud to be a podiatrist, and I want to share how I believe the role that podiatrists can play in falls prevention among all older adults, and specifically among people living with diabetes. I will share with you very proudly as well, we have a parent organization in podiatry. It's called the American Podiatric Medical Association, and every year they choose an educational initiative, which is both professional for us, but it's also an external facing educational public campaign. And I think this webinar is very timely. Last year's educational initiative for the APMA was the role of podiatrists in falls prevention. So I think it's very much at the forefront of what we do. And I want to share some of the some thoughts around that with you all today. So, if I was to summarize what I believe the role of the podiatrist in falls prevention should be, it would be in these four main areas. Of course, appropriate foot care. So, how do we manage foot pain, arthritic conditions, biomechanical abnormalities, foot ulcers, so that we can maintain fit? Literally, the goal of every podiatrist is to keep patients on their feet and keep them ambulatory, because we know that ambulatory status is really key to quality of life. We're going to talk about shoes, but a common, obviously, question that I receive on a daily basis in clinic is, what types of shoes should I be wearing? Whether you're a runner or an older adult, but we can provide appropriate footwear advice. And of course, you all know patients with diabetes, hopefully, if they meet risk factors, they're taking advantage of therapeutic shoes, and we can talk about that as well. I think at the core of what podiatrists do, it's education and health promotion. So again, how can we keep people ambulatory, and those appropriate foot education tips and pearls, which I'll share at the end of this so that you can share with your patients. But really, I consider myself a teacher, whether it's to colleagues or most importantly to patients, what we can do for health education. And finally, I would say we really want to be part of that collaborative, multidisciplinary team. You all know in managing people with diabetes, it takes a village. And so this bi-directional kind of collaborative effect that we see is really beneficial to patients. So as a podiatrist, I want to see everyone who's at risk for potential falls prevention to see how I can help them. Of course, we do annual comprehensive diabetic foot exams, But my common referrals back are to physical therapists to make sure that patients are maximized for a home exercise program or assistive devices if they are indicated for falls prevention. We do a lot of referrals to our orthotics and prosthetics colleagues, again, for appropriate inserts, whether they be custom or braces, and all of these tools in the box. So understanding that it takes the village is really, really important. So once again, leaning into some literature, this is a landmark study. It's about 15 years old now, but this was really what put us on the map in terms of recognizing that podiatrists do have a role in prevention of falls. So what we see is that this was actually a prospective trial of over 300 patients where the control group received what we would call standard podiatry care. Then the intervention group, I'm going to call it kind of enhanced podiatry care. So that enhanced group received prefabricated custom orthotics to offload painful calluses in the forefoot. So again, we don't want pain to be in the way of ambulation ability and or be a risk factor for falls. These folks in the enhanced group received specific advice on footwear, and very nice to be participant in that arm of the study. They actually received a financial voucher to purchase appropriate shoes they were given advice on. They were also given a very structured home-based exercise program for foot and ankle specific exercises, a falls prevention booklet, and also received that same routine podiatric care. Again, this was over 300 patients, and I want to share some of the results with you. So, what did we see in that enhanced group? All of the patients in the enhanced group over the 1 year period of study actually saw a reduction in falls of 36%. And that was fairly consistent with what else is published in the literature. When you really receive comprehensive podiatric care and you're under the routine care of a podiatrist who really focuses on things, on falls prevention ideas and techniques, we see that there is a significant reduction. A lot of the benefit of the podiatric enhanced group was attributed to the exercise, and maintaining that strength and balance became really kind of apparent that it was a key component to the success of the falls prevention portion of this program. We're going to talk about Tai Chi because that consistently comes up in the literature as a very strong recommendation. But again, this study just showed that enhanced podiatric care, it really truly will reduce falls risk and incidence among a high-risk patient population. So let's spend a few minutes again talking about shoes and inserts. And this is, again, such a common daily occurrence for me in my podiatry practice that people will ask and seek my advice about shoes. And while I'm very hesitant always to give a specific name brand, I do like to review with patients, individual and personalize their care, but there are certainly common characteristics when people ask my advice. There are common characteristics of the ideal shoe, and I have them here on the slide for us. Of course, and especially this is focused towards more older adults who have that risk for falling. We want to make sure that there's a really nice wide square toe box to reduce pressure on the toes and make sure that there is plenty of room, especially if there are any foot deformities like hammer toes or bunions, which may not do well in a more kind of pointed toed type shoe. We always recommend a closed heel counter. So open back shoes, flip flops, those types of things are generally not as supportive as you might suspect. But we really do want that nice heel counter to be cushioned and closed in. I really stress to my patients about getting fitted for appropriate shoes. And I admit that this can be a challenge, especially today. Here in Ann Arbor, we're very fortunate. There's a long-standing, open, family-run shoe business that I refer a lot of patients to. But sending your patient to the mall where a high school kid is kind of working and not really in tune with the old, I know many of you may think and remember and take back to your childhood, like to mine, that Brannick device, which was that silver and black device that you would stand on, and it had lots of little lines, and it had those kind of silver gauges that kind of came in to decide were you a narrow, a regular, or a wide, and what shoe size were you? I don't see those in shoe stores anymore. So really have to seek out appropriate guidance because many people's foot will change shape and size over time. That's just a normal occurrence. So thinking that you're the same shoe size as when you graduated high school, it is not really common. Other shoe kind of characteristics, we want them to be fairly soft and flexible with breathable uppers, but not too flexible where you can truly twist the shoe because we do need that additional support. Especially for people with diabetes and neuropathy, we want to watch and make sure that there's no significant seams that in a person with neuropathy could cause irritation and potentially even friction, blistering, and or wounds. Shock absorbing sole. All of us like a good cushioned shoe that feels like you're walking on a pillow. Non-resistant, slip non-resistant soles are really, really important. We don't want patients to slide and glide across the room. A broad heel, if at all a heel, not something that's very narrow or the classic kind of stiletto looking. And then many of our patients really need that adjustable fastening for support, especially if they have issues with repeated swelling, right? So one day they may have significant swelling, one day they may not have any swelling in their feet. So really the ability to either have laces or Velcro closure is really, kind of ideal. And again, now you might have in your mind's eye that this doesn't look like or sound like a pretty type shoe, but we've got some examples on the next slide here. And I would think, none of these aren't too bad. And these actually come from a CDC resource. And Betsy's going to provide some of those resources towards the end of the webinar. But these are examples here that we've taken from the CDC to share with characteristics of ideal shoes. So I also mentioned I like my talks to be evidence-based, but I also want you to hopefully have some practical intervention. So what I want to share next is this Cochrane review on interventions. So I think we've established that there's a problem. We know the risk factors. We know that there are some unique risk factors in people with diabetes. We know that podiatrists potentially can have an influence. Well, what can you do, or what does the evidence-based medicine show in terms of interventions for preventing falls in older people living in the community? And again, this is a really nice summary. It is a Cochrane review of 111 randomized clinical trials on this topic, which represent over 53,000 patient participants. So I like these because they give us the important evidence base that's been published in peer review studies. So let's dive into what the findings were. So again, I've alluded to this earlier. The literature is very clear that exercise in older adults is a very significant intervention for falls prevention. And there have to be the four components of strength, balance, flexibility, and endurance. And repeatedly in the literature, Tai Chi will come up as the number one hit to address those four key components of exercise. So, and when you address those, you really do reduce fall risk among older adults. Tai Chi, again, is a frequent recommendation that I give my patients. And it's wonderful if there's a local YMCA or community center which may have a program or a class of Tai Chi. But today, I even recommend to my patients to go onto YouTube, stay in their living room, right? And see if they may want to try a Tai Chi class. What I also love about Tai Chi is that it's very slow and deliberate movements. And in my practice, my population is at risk for diabetic foot ulcers. So while I would love them to exercise and do really consistent weight bearing exercises, some for our patients, sometimes it's not advantageous to do that significant weight bearing, that amount of weight bearing, because they're at risk for foot wounds and foot ulcers. So Tai Chi is very slow and deliberate. You can even do a lot of Tai Chi from a seated position. So it's a very common recommendation that I give my patients. And again, very much supported through evidence-based medicine. So this Cochrane review also looked at other interventions to see, okay, well, Tai Chi and exercise, we know that that is a positive, but are there other things that maybe we shouldn't be recommending? At one point, we thought vitamin D levels, we're blaming vitamin D deficiency on a lot of things. And we thought maybe that was associated with fall risk as well. Well, the evidence-based medicine doesn't pan out. And vitamin D supplementation does not seem to mitigate the risk of falls. This is an interesting one. I always thought that, as the kind of photo shows here, putting up these grab bars, especially in people's homes, may reduce the risk of falls. But the literature is kind of mixed about that. If you know that a person is very high risk and they have a specific need in their bathroom, then yes, you may want to recommend grab bars. And I'm not an expert in this, but there are people who are, and typically they're occupational therapists who may actually go into the home and make recommendations around kind of these home safety manipulations, if you will. But what I've heard and what I've read is, like in the clinical photo here, more is not necessarily better. Because if a patient does have a fall, they might actually now hit their head on that bar. And it might cause more damage than the benefit of having it there. We do know, as your intuition might suspect, that wearing an anti-slip shoe in an icy condition would reduce risk of falls. Sometimes I think evidence-based medicine just proves the obvious, but it is important to prove it through evidence-based medicine. We also know, as we talked about fairly extensively, certain medications increase the risk of falls. And then certain procedures can actually, again, reduce the risk of falls. So cataract surgery, if you have visual impairment and vision is improved, there is a lower risk of fall. Pacemaker surgery for conditions that affect heart rate and blood pressure, like carotid sinus hypersensitivity. So having a pacemaker placed can actually reduce the risk of falls. So again, personalized medicine, but these are the consistent things which tend to come up in this Cochrane review as evidence-based interventions to include or not include based on the individual person in front of you. So if I was to summarize the evidence-based interventions for falls prevention, there's kind of three big buckets. One is home hazard modifications, and I've alluded to this. And in health systems that do have falls prevention clinics, they may actually have social workers or occupational therapists who can go into a home and do those home evaluations to assess whether or not the bathroom should include grab bars, but also things like throw rugs and cords. And these are common risk factors or trip hazards, if you will. And certainly removing those offensive, potentially offensive issues like throw rugs can be a significant help. I mentioned the role, obviously, of podiatrists. So I think footwear and orthotics, and the way I explain orthotics and why we think they're so beneficial, an orthotic is the insert that we put into a shoe. Hopefully, if it's custom, the orthotic, instead of allowing the foot to collapse to the floor, really provides stability by bringing the floor up to the foot. So that's what an orthotic does, and really truly levels the playing ground for the patient to be able to walk on an even surface instead of manipulating up and down and the foot having to maneuver within a shoe. So custom orthotics in appropriate shoes can really have a very significant influence. And I hope I've shared with you, of course, the significant role that exercise, specifically that we talk about strength, endurance, balance, can have on overall mitigation of falls. So here's where hopefully the next patient intervention that you have and that you're discussing these fall prevention recommendations, here's some specific tips that I would have you share. And these are what I hopefully talk about with my patients. So obviously wearing shoes that keep patients safe and fit well. And again, we talked about this, making sure that they're being fitted for appropriate shoes, really avoiding those backless shoes, flip-flops, clog style. There's just not enough support. If they are going to have a heel, make sure that they're low and flat and broad, and really walking around in socks. And I know so many people do this, but actually that's a fall risk factor, right? Is because there's just no grip and support, and it's really not advantageous to have patients just walk in their stocking feet. We talked about shoes and inserts. So again, sharing with patients, have you been evaluated by a podiatrist? You might benefit from custom orthotics and or shoes recommendations, and they don't have to be very expensive. There are some really decent shoes that are not crazy expensive, but share those ideal characteristics that we talked about before. Talking about exercise, so building strength in feet and toes, whether they be while patients are reading or watching TV, just keeping those feet moving, grabbing a tennis ball to really encourage, or a towel that you put on the floor, have patients grab those and exercise their toes. That can really, really promote postural stability and balance. There's a few more, making sure that the medications, whether it is talking with your primary care physician or you're fortunate to work with a pharmacist, the patients really need comprehensive reconciliations every now and again, so that they can really make sure that the medication dosages are optimized, that the interactions are minimized, and that if they are on those medicines and there are side effects that potentially could put people at risk for falls, that we address those and we take special precautions. Encouraging patients to have their annual vision and hearing exams. Again, this audience needs no explanation of following ADA guidelines, making recommendations around annual foot care visits, annual vision visits, hearing, dental, all of those. I believe if we all just followed ADA guidelines, again, risks would be minimized. And again, thinking about if patients can on their own identify those trip hazards, throw rugs. I think about my own dad. I'm very fortunate. My dad turned 95 last November, and I was at his apartment not too long ago, and he has this small kind of throw rug underneath the ottoman that he uses to elevate his feet. I said, "Hey, Dad, why you have that little throw rug there? It's a trip hazard." And he wants to protect the carpet, right, from the little legs of the ottoman. I said, "Hey, we'll replace the carpet. I don't want you to fall." So having that conversation, whether it's you as a medical professional or with somebody that you love, and understanding obviously that having an extension cord to make sure that the lamp is in the specific place that they want. We want to minimize the risk of those being fall and trip hazards. So identifying those on your own or through the help of the patient as well. Canes and walkers, obviously a lot of people will use assistive devices, and theoretically they're helpful to minimize the risk of falls, but we really need to make sure that they're appropriately prescribed, that patients are appropriately trained on how to use them, and that patients will use them, right? That they don't just necessarily leave them at the door only for outside use. If they need it, they probably need it inside as well. And then I know many of you are familiar with the concepts, but I'd be remiss if I didn't talk about fear of falling. We know that a previous history of fall, as I said before, is such a strong predictor, but there's also this fear of falling. It's real. And once you've experienced that, you just don't want the subsequent falls. So people will tend to be more reclusive. They don't experience life as much. And of course, we don't want that as well. So how can we talk about these things to make sure that people are living healthy, productive lives? So just to spend a quick minute, I want to talk about us as providers and making sure that we're aware of all of the resources that are available wherever we practice. Again, many health systems are very lucky that they have falls prevention clinic. It might be run by the physical therapy department, but as providers, are we aware of what resources are available? The most common thing I hear is that falls prevention clinics are at risk to go away because they're underutilized within healthcare systems. So making sure that we know the criteria and that we're trying to be proactive and do primary prevention and not just wait until patients have already experienced falls, but be proactive about it and get them into the physical therapy department or the falls prevention clinic so that they can have comprehensive education and evaluation. And I mentioned the idea of assistive devices and who made the recommendation. Are they buying a walker off of Amazon or did they get it from a neighbor? We all know the story. Somebody passes away and they're cleaning out the apartment and they say, hey, do you want mom's old walker? Well, that person might have been 5'2" and I'm 5'11", right? So we need to make sure that people, if they're using the assistive devices, it's obviously best to come from a healthcare professional, but also to make sure that patients are trained appropriately, typically, again, through physical therapists. And this is my last slide with my key takeaways for you. We know and we've reviewed diabetes significantly increases fall risk due to complications primarily from peripheral neuropathy and from hypoglycemia. I hope I've shown you that podiatrists can play a critical role in managing foot health and hopefully education on falls prevention. And then the evidence-based interventions like exercise programs and home modifications can be very effective strategies for reducing falls. I'm going to turn it back over to Betsy, and I'll see you all for the Q&A in just a few minutes.
Thank you, Dr. Rothenberg, for an amazing presentation. Now I will share some additional resources from CDC that you can use and share in your work. CDC Injury Center created STEADY initiative, and this is to help provide resources, tools, and guidance in treating older adults who are at risk or failing or who have fallen in the past. Their work focuses on screening patients at risk for falling, assessing risk factors, and use evidence-based clinical and community strategies to reduce the risk of fall. CDC Study has many resources to help you screen, assess, and intervene for falls. Two of the resources can see now on the screen. The first is a checklist to help you assess risk factors, and the second is a feet and footwear fact sheet for older adults. They also have referral forms, success stories, videos, and more. Many of the resources, like brochures, are also available in Spanish. Find all the resources at cdc.gov/steady. So CDC has also more resources highlighting foot health. As Dr. Rothenberg emphasized earlier, team-based care is important to managing diabetes. So share this with your network to ensure consistent communication about lower limb health and fall prevention. We have tips to prevent serious foot problems, and you can share this with people living with diabetes. We also have our promoting food health webpage, which has key messages and information you can share with patients. You can access the site by scanning the QRC code on the screen, and we will put the link on the chat. So now we're moving into the Q&A portion of this webinar. And Kathleen and other, have you seen any questions in the Q&A box? If not, for those who are attending this webinar, this is your time to raise your questions. Please use the Q&A box to write your questions there.
Great, thanks. And while we're waiting, again, you can submit questions in the Q&A box. Do have one question, and it builds off the video you just shared. Visits with patients are short. There's not a lot of time, or regardless of what setting you're in, your time with people with diabetes can be limited. Other suggestions, Dr. Rothenberg, for what you can do in a short amount of time to get at falls risk?
Yeah, I appreciate that. I think, there are several key questions that you can ask the patient. Um, and of course, if you do have the time and the knowledge and experience, doing those stand up and go tests are wonderful. But I simply think, as a podiatrist, I will ask, have you had any falls between the last time that I saw you? And typically, I see my patients who are at high risk with diabetes. I'm seeing them basically every 3 to 4 months. So, have you experienced any falls in the past since I saw you last? And do you have a fear of falling? I think those two questions as a screening tool are super useful. And obviously, if they say yes or yes, then I would dive a little bit deeper and go through those risk factors and see if there's anything. But again, I'm not a pharmacist. So then it would help me to identify where I might collaborate, or if my health system, which we're very fortunate here at the University of Michigan, again, I might refer to the patient to the falls prevention clinic if they've never been seen there before.
One thing that I usually do, Dr. Rothenberg, is to advise my patients to look to do at least 2 times per year, I will say, talk with the pharmacist to do medication reconciliation. So look to all the medications they have been taking and see if there are some of those that can prompt people to falls. I think that has been helping them. You've been to be proactive and be able to identify potential falls by just doing that. Can you expand a little bit on that?
I completely agree. And again, sometimes I even tell my patients, if you're having a bad day and your neuropathy is really significant, one of the reasons we like gabapentin is because you can titrate and you can work with it. So sometimes patients are self increasing their dosages. So we have to be cautious about that among this patient population. I totally agree with you. I think it's the changes. And based on what I explained, and it resonated with me as I was preparing for this talk, is that idea of medicine reconciliations. I think we understand as a profession, especially after you're hospitalized, right? Why is it so important to do that upon discharge or immediately post discharge? So twice a year. But I would add and go so far as to say, for recently hospitalized patients, that work with a pharmacist can be very, very important.
I also have the tendency to look for the number of hypoglycemia events they have had before I have seen them, because that also will give me some cues. Can you expand a little bit on that as well?
Yeah, I agree. Certainly, continuous glucose monitors, right? They have helped us tremendously to understand people's patterns. And so, absolutely, if we know that hypoglycemia is a risk factor, and we can see that patients are consistently going low after breakfast or dinner or whatever it is, we can make the assumption that it's based on what they're eating or their medication dosage. So, certainly using technology like CGMs if they're available to us, but understanding that hypoglycemia is a strong predictor of imbalance and, as we talked about, confusion, where all those states can predispose people to falls. So, yep, I
But
think
even if they don't have the access to that technology, just the traditional blood sugar log can help you identify how many episodes of hypoglycemia or low blood sugar reaction you have had in the last 3 weeks or 2 months or whatever the time frame it is from the last time we have seen them. It definitely will help us and will help them identify the risk for falling.
I agree.
Another question we have is if a patient has neuropathy, what are some exercises they can do beyond walking?
Yeah, I appreciate that. Again, this is a struggle that I have with a lot of my colleagues because, of course, an endocrinologist or a primary care physician in managing somebody with diabetes is going to recommend right walking. It's so easy, it's cheap. Have your dinner, and we all know the statistics. Taking a 15-20 minute walk after dinner will really help with glycemic control. So but the fight that I have is in my high risk patients who either have already had diabetic foot ulcers or have had amputations, right? And they just kind of I think there's wonderful intentions, but just making that broad recommendation for weight bearing exercises, we need to individualize the care. So I talk with my patients. Yes, I want the cardiovascular and the glycemic benefit of aerobic exercise, but the alternatives are for these patients are really, really important. Especially obviously if there's an open wound, I don't recommend swimming, but swimming, non-weight bearing, right? No zero gravity, no stress on joints, especially for our older adults who have arthritis in their knees and hip and in their feet. Swimming is wonderful. Then my next favorite kind of category would be non-weight bearing exercises, whether it's a stationary bike or elliptical machine, right? Where your feet are planted, not where there's this high impact pounding on a repeated, hard treadmill. Um, if patients do enjoy walking, I want them to do that, but then I take extra precautions and I make sure that they have appropriate shoes and inserts and that they're checking their feet consistently and routinely. And of course, it's specific to this talk, we talked about Tai Chi, and I love that as a non weight bearing exercise. Whether you do it in a chair or it could be weight bearing, but very slow and deliberate, not high impact. So yeah, those are the my go-tos for people with neuropathy at risk for foot wounds and ulcers. Is going to be swimming if people have access, non-weight bearing activities, and then cautious weight bearing activities with the caveat that they have appropriate shoes, inserts, and that they're checking their feet routinely.
There are some other recommendations that I also share with them, Dr. Rothenberg, for example, seated leg extensions. That's something that will keep people, moving, but while sitting. And I also think about resistance bands on legs and arms while sitting. That could be also a very good way on how to keep mobility. And I also think that the importance of what you mentioned before, which is to check feet for cuts, for blister, for swelling before and after doing any type of physical activity. The proper shoes, as you just mentioned, the hydration is also very important. Drink water, drink water. We all need just to drink water. We don't need anything else. And of course, avoiding those high impact activities like running, jumping, heavy lifting without any supervision. I think that the best advice is always to consult with your physician before getting in any type of physical activity.
I would also go so far, Betsy. We're experiencing so many patients with, especially as we age, with mental health issues, right? Depression and diabetes and anxiety. Like these, if people are fortunate enough to find the resources in their community where they can go and do chair calisthenics, right? And
Yeah.
interact with people. Again, I bring my dad up as an example. He lives in an independent living facility, but where they provide these activities and going down to the activity room and interacting with people. It's good for the body, it's good for the mind as well. So, really encourage our folks to, yes, take the appropriate precautions, talk to your healthcare providers, but be involved in the community, right? In your local community as you can.
Well, Dr. Rothenberg, I'm 69, so I fit into the older adult category. And one of the things that I did actually was to call my health insurance. And they were very helpful. They helped me register into a type of program that they cover. And I am on a gym with a coach who's working hand by hand with my care team. And they have been able to set a routine that is safe for me, and I am becoming very active and being able to do many things that I wasn't able to do before. In other words, I have become more functional because I have healthcare professionals and the health insurance working with me. So I will advise people to look to the back part of your insurance card and call those people. Sometimes we have resources that are we're not even aware that we have it. And I think that that would be a good start for people to, just call the health insurance or call the agency, Department of Health in your state. They might have resources there, community-based driven resources that can help people find the right groups and the right resources to be physically active despite of living with diabetes or have diabetic neuropathy.
That's right. I love that, Betsy. And those health plans and the community centers want people to come because they're at risk, right? If nobody's using them, the health plan is going to take away that service. So yes,
Yes.
we have to encourage our patients to utilize those programs. I love that.
Thank you to everyone in the audience for these questions. And if you have additional questions, please send them to the email address on your screen. We follow up with you after the webinar. This concludes our webinar. As a reminder, a recording of this webinar and the slide will be shared in the near future. Thank you for joining us today.